but first, the two choices here. So you can choose to either hear from Dr. Robin Kenter, who is a postdoctoral research fellow at the Department of Clinical Psychology at University of Bergen in Norway. She will present and then answer questions from the Norwegian perspective and the planned use of the It Fits toolkit by the Center for Mobile Mental Health in seeking to increase the use and impact of digital psychological interventions in Norway. So that's one project aiming to use the It Fits toolkit after this project ends. And another project also aiming to use the It Fits toolkit. For that, we're pleased to welcome Jinan Abir from the National Mental Health Program in Lebanon and Ken Carswell from the World Health Organization to offer the Lebanese perspective and the planned use of the toolkit in rolling out Step by Step, which is an electronic mental health intervention.
Thank you for joining this session today. I'm really happy to see you here all on my screen. My name is Robin Kenter, and I will talk about our National Norwegian Research Center, which is called the Center for Mobile Mental Health, about how we are funded and what we are planning to do. And I will go first into the situation regarding mental health care in Norway, about how we are organized and how much, or I should say how little, guided internet treatment we use in specialized mental health care today. And then at the end of my presentation, I go in how we are planning to use the It Fits toolkit. So if you have any questions, you can write them down in the chat, and I will try to answer them at the end of my presentation, because then we have some room for discussion. So first, in order for you to understand the setting the center operates in, I will explain in short the Norwegian healthcare system. So Norway has universal health coverage, which is funded primarily by the general taxes and by payroll contributions shared by employers and employees. And that ensures that all inhabitants have equal access regardless of social status, income, or location. And while a healthcare policy is controlled centrally by the national government, the responsibility for the provision of healthcare is decentralized to 4 health authorities, which you can see on the map. So the map is Norway, and the different colors are the different regional health authorities. So psychiatric services in hospitals and outpatient clinics are funded in full through the regional health authorities. So with this in mind, what happens if you experience problems of moderate depression or anxiety, for example, in Norway? So this is you. You have symptoms of moderate depression or anxiety and you want help. In Norway, then you first have to go to your GP. Because that's the one that can refer you to an outpatient clinic in which you get treatment. Now, the problem is that we know that patients do not always go to their GP for help. In social anxiety, for example, a recent survey showed that it takes up to 12 years before they first ask for help for their problems. And then if you go to your GP has to recognize that you have symptoms of depression or anxiety and then refer you to the right care. And then there's often a waiting list. So we're not that different from the rest of Europe. We have this treatment gap that only 20 to 25% of those in need of psychological treatment receive that kind of treatment in time. We also have large geographical distances, which makes traveling to the clinic difficult. So it's not uncommon that people have to travel for 2.5 hours in order to get one face-to-face consultation. We have stigma, we have long waiting lists, and so on. We have all these barriers that are known. But if you're admitted, say you're admitted to an outpatient clinic, then you often receive individual face-to-face consultations. And that model is not sustainable, especially now in a pandemic, but also regarding the amount of patients that are in need of treatment. It's a costly model, but typical to Norway is that there's also incredibly high costs related to sick leave. So employment in Norway is among the highest in the OECD countries, but compared to these countries, Norway has a very high sickness absent rate. And it's even so that Norway has the highest mental health related unemployment gap and disability benefit caseload. So in other words, we pay lots of sickness benefits to those with anxiety and depression. So the national government recognizes this, and they recognize that we should increase access to and the quality of treatment for mental health disorders. And in the picture, you see our health minister visiting one of our internet-based clinics. And the government has all these strategies now that promote digitalization of mental health services, because this, especially internet-delivered treatment, is thought to be a good evidence-based treatment for anxiety and depression, and also that it offers an extra service and overcomes these barriers with, for example, traveling to the clinic. So the government and the health authorities, they push this digitalization now. But it's not only them, it's also the patients. So the Norwegian citizens express the need for an increased use of technology in mental health services. So in a recent survey, it shows that 84% of Norwegian population say that they are positive about the use of new technology in mental health care, and that they already use, especially the internet, for finding information about their mental health problems. So, but with all this in mind, and even now in the pandemic and the push from the health authorities and the wish from the patients themselves, we have very little use of guided internet-delivered interventions in especially specialized psychological health care. So today we only have one therapist-guided internet-delivered treatment that is available in specialized mental health care, just one. And it's called the e-coping clinic, or e-meistring, and it's based on the Swedish program which Per Kaldring and Gerhard Andersen generously offered to the clinic in 2007, and it's ICBT for social anxiety, panic disorder, or depression. And it consists of 2 face-to-face consultations, one at the beginning and one at the end of treatment. And yeah, in the middle, it's just your standard guided ICBT. And for the record, you have to believe me that we offer effective treatment. I will go in now that even though we have this effective ICBT treatment, the road to implementation has been very difficult. So it started as research in the Bergen area in 2012. Then the first real patient outside research was receiving the e-coping treatment in Bergen. In 2015, it was in operation in Bergen, but we had no reimbursement. So we didn't get funded from the government. We didn't get paid to do this kind of treatment. Then in 2019, it was approved after a health technology assessment by the Ministry of Health and the regional health authorities. And this was major to the uptake of this kind of treatment, because then they got full reimbursement in 2019. And in the fall, it starts spreading in the Western Norway region. And now, from 2021 and 2022, the idea is that the e-coping treatment, so these 3 treatment programs, will be in use in all of the Norwegian health regions. But we don't know how we should do this, and we don't know how we should organize. What we know from in the Bergen area is that there are some barriers and facilitators. So we have these attitudes of therapists that many of our colleagues are uncertain about the effect of technological solution and what it does to the quality of the relationship between patients and therapists. And they also fear that technology will take over the work tasks. There was this major issue with reimbursement. Referrals are still not optimal. a lot of GPs don't know that they can refer to guided internet treatment solutions. There was a major barrier with technology and safety. I believe that Norway is one of the strictest, the most strict with patient data. So it's been really hard to have this platform storing the data, being into the outpatient clinic and hospital settings. It was a major barrier there. Facilitators were training and education of therapists, continuous peer guidance. So what they did in the e-coping clinic is that all the therapists, they have a rule now that all the therapists have to work 50% with e-coping, and that they have to sit together with other therapists so that they can learn from each other and get really good at giving guided ICVT. A major facilitator was also that in the Bergen area, patients could self-refer to the treatment. But that's only in Bergen, so that's not in the rest of Norway. So the road ahead for the e-coping clinic is that they want to offer high quality of treatment. So they're doing some studies about the optimization of guidance, the optimal amount of sessions, how they can tweak the platform, that it increases user satisfaction and better user interaction. They want to further develop existing and also new programs and ensure cost-effective and sustainable models for dissemination. And the idea is that we then roll out the e-coping clinic in the entire Norway. And this is where our new research center comes in. So it was a long introduction to get here, but this is our research center. So we call it For Helse in Norwegian, or the Center for Mobile Mental Health in English. This is the center leader, it's Stine Norweigan, and these are all our project partners. And the main aim of the center is that we, by 2030, that 20% of mental health treatment is accessed digitally. And it's not only the center's idea, but it also is the same aim that the health authorities have, and also that our national government has. So now we're in 2021. I think a really positive estimate would be that 3.5% of patients are treated digitally in the clinic that have the e-coping treatment. And then again, that's not a lot of clinics. I believe we're 7 in the entire Norway. There are only 7 clinics that offer internet-based treatment. So it's we have to expand the use, yeah, we do this in our project. So we have an 8-year project, and we are funded through the Norwegian it's called funding agency. And the objective of this type of funding is to enhance innovation and value creation in the public and private sector. So in our case, we have hospitals in the public sector, but they don't house or develop technology. So that happens in these private businesses. So there are codependencies, right? The private businesses want to distribute their technology into the hospital settings, and the hospital setting should buy into that. But in order to ensure quality, we have researchers in our project so that we can do research on how we can do this in the best way. So we received 18.5 million euros in funding for an operational period of 8 years. And the private businesses, they don't get any funding themselves, so they have to pay in order to be part of the project. So the research questions are really driven from our partners, so from our IT companies, from the outpatient clinics. Yeah, so as I said, the center's primary objective is to expand the use and the impact of digital interventions. And we try to do this by research on early health technology assessment, on effectiveness of these treatments compared to standard treatment, on health, economic and socioeconomic impacts, and also on implementation strategies. And this translates to these VPs that you see in the figure, and they kind of feed into each other. So just to give you an example, we have this entirely new intervention that needs to be developed. That's an intervention for back pain. So it goes through an early HTA assessment, and then we have development of the intervention, effectiveness research, cost effectiveness research, and then it goes, if the results are good, we try to implement this in order to go to our goal, which is 20% in 2030. So the center will develop internet-based interventions that are psychological, but not only in outpatient clinics, but also in somatic care. So in VP4, I am the VP leader of the implementation work package. We now start in the first years with implementation of e-coping, the internet, the ICBT, which I told you about, because we know that it is effective, it's safe to use, and it's a more mature intervention that we can roll out over Norway. So the situation today with regard to implementation, there are 7 e-coping clinics in Norway, but the regional health authorities have the responsibility to implement e-coping in their region. So there's money available, there's time available to do this. And they have decided that one outpatient clinic would be responsible for quality assurance and is provided with the task of implementation in their region. So now it's 7 e-coping clinics. But I don't think it's an overestimation if we say that, because there's a lot of interest in using e-coping, that perhaps it will roll out over more than 30 outpatient clinics in the next year. Yeah, so the task of our VP is to understand the determinants of practice in relation to scaling up ICBT. So we look at local barriers and facilitators, because even though it's one country, because of the geographical distances, it's quite different in the north compared to the south. People are maybe quite different on how they are organized in outpatient clinics. So we look at these local barriers and facilitators, and also the organizational structures, in order to see if there is a good way to do this implementation. So we are planning for a multi-center study on tailored implementation strategies. So compared to the implemental project, maybe we have less heterogeneity because all will use the e-coping programs. They will use the same platform, the same intervention, and it's in Norway, so the same funding structure as well. So what we plan to do with It Fits, because it's not just us researchers that have thought of, okay, maybe we can use It Fits. It's really a question that it's driven from these outpatient clinics, which are partners in our project, right? So they spend a lot of money participating in our project because they want to do this implementation right. And there were ideas about maybe we should do this in a structured manner. And that's where It Fits comes in. We've heard in the panel discussions that you really have to focus on one barrier and do this in a structured way. So we are really excited to use It Fits toolkit. The plan is that we use the toolkit in 5 sites first. The sites that are already working with implementing e-coping. And that when we get more outpatient clinics that participate in the project, that we roll this out to other sites. We will also have some crossover clusters. We try to do some both quantitative and qualitative, right? So some interviews, maybe a Delphi method. We do some observations, etc. The thing is, it is quite open. So we started now in December, and the first task of the work package for implementation was to write the study protocol. So I'm really, really excited in a discussion afterwards, if you maybe have some ideas on how we can do this in a good way. Yes, I would like to acknowledge our funding agencies and the Norwegian Research Council, the center leader, Tina Norweigan, all partners in the project, the patients, the therapists involved, Kristin Bruvik from e-Meistring, who's done an amazing job with leading e-Meistring and spreading it, and all our outpatient clinics involved in implementation activities. If you have any questions and I can't answer them in the chat, you can send me an email or visit our website, which will be in English after Easter. All right, I stopped sharing my screen. And then Mette, are there any, you can also unmute and just spill out your question. That's also perfect.
Yeah, we don't have any questions in the chat just yet, but you're welcome to just speak out.
Can I ask a question?
Go ahead.
Yes, please.
I was wondering, you're talking about you want to have a look at the determinants, the various facilitators, but also the organizational structures of the different sites. And I was just wondering, how are you going to do that? And, you know, what level of detail are you thinking about?
Oh, thank you. That's a really good question. So as I said, we just have an idea. So we don't have the study protocol in detail ready yet. But the idea is, right, that if you organize this internet-based treatment in a different way, right, because some outpatient clinics have it as an own section. So they have just a section for internet therapy, and they have therapists that are employed at that section, and we see that that works really good, because then the therapists are committed. They use their time, spend the time that they have spending on ICBT, and in the clinics that don't have that just have two therapists that are really enthusiastic, we often see that when it gets busy, that they just don't include in the ICBT, but that the face-to-face consultations have will be preferred, right? Mm-hmm. So what we do is that we have all these documents. So we have interviews with the leaders and the people working in all these different outpatient clinics. We have a monthly questionnaire that we now send out to our partners, in which they have to answer about how they are organized. So we do this both with looking through the documents, asking them, and have some standardized questions in our monthly or bi-monthly questionnaire that we send out.
Okay, yeah, sounds good. Yeah, I was just wondering because I'm working on a multi-center project as well. It's a different topic. It's in e-health for patients with ALS, so it's not mental health. But we're dealing with different teams in different organizations as well. So and we're already rolling it out. But now sometimes we see that in some organizations it goes better than in other organizations, and we haven't done anything to really capture the organizational differences. Apart from some are rural, some are urban, and some are big and some are small. But yeah, of course there are more in-depth differences in organizations, and I was wondering how
it's interesting that you say that, because now I only presented about the ICBT, right? But in the project, there are also, we have this internet-based treatment for people with irritable bowel syndrome that has proven to be effective. And they, because of different funding, because they are in the hospital, they plan to be a national center. So just get in all the patients from from Norway, but are located just in Bergen. And that is something to say about how difficult it is to get it implemented, right? Yeah. Compared to go to every separate outpatient clinic and try to have the same quality of treatment. So that is something that we are aware of. So that's something we try to get a good overview. But I'm open to ideas on how to do this and do this right.
Me too.
Yeah.
Thank you.
Thank you. Are there any other questions? Just to unmute and shout out if you're wondering.
Maybe just a question about the sites. I think 5 sites you said that you are trying to roll it out in the trial too. Have they already been introduced to the e-coping intervention, or would they be completely new? Because I remember you said something about, you know, 9 sites are already working with it.
Yeah, so we have 7 sites already working with it. So these 5 sites some of the sites are working with the e-coping for several years now. But 1 site started in February, 1 site will start in September, and the 3 others already have started in, I believe it was the fall of 2022. So yeah, so a mixed amount of experience there. But they are familiar with what it is, but they have never, some of the sites have never worked with it. And then and these 5 sites are only prioritized because they start this year. But we expect that because it's the regional health authorities, right, that has said, okay, we're going to do this no matter what. You can either say, I want this as an outpatient clinic, or you can say, okay, just keep my treatment as I want to. So we expect that lots of outpatient clinics will show an interest and want to participate. So then from 2022, all the sites will be new to ICBT. Do you think it would be more difficult or less difficult if you're new to the treatment?
I don't know. I mean, I guess it's similar to EMA as well. Some of the sites, they were completely new to using ICBT interventions, whereas others, you know, they've sort of like much further on in the implementation process, trying to kind of refine things.
Yeah.
I mean, in terms of the It Fits toolkit, I think, you know, you could use it either way, but I think before people got introduced to the EMA trial, there was some preparation work in terms of getting sites, you know, developing a very basic infrastructure for them to kind of deliver it.
Yeah. So in our trial, the sites that are participating, they have this platform that is made for existing in their existing technology structures. So it shouldn't be, now I have to be careful, but it shouldn't be too big of a problem, the technological part of it. Yeah. Are there any other questions?
I have a question for you. One of the things, and I'm seeing Eric here, and he's sort of sitting always on the shoulder, telling about the patient perspective. How are you if at all, and how are you planning to include that in the implementation rollout, so to say?
Yeah, so we are aware of that, and we also take that into account. So how it exactly precisely will be, we don't know, but we plan to have some qualitative data on how did you as a patient experience being part or being treated with ICBT, and then just not the focus on the ICBT program, but the whole pathway from, okay, I have problems to how do I get to the treatment. So we have some collaborations from Tromsø, from the university in the north, that will help us to measure that as well.
Thanks, because yeah, I think it's important, but also very challenging to bring all those stakeholders together in basically one room or time, let's say space, or however, but to connect all those things. So yeah, important thing to keep in mind. Thanks.
Hello, this is Eric. I missed quite a substantial part of your explanation, but anyway, following the question of Christian, what I wonder in general is, okay, you have an implementation process, and also in implemental, look to what the effect is on the implementation process itself, with the leads and the GPs and everything. But when there is a change in the way of working of these healthcarers, do you have any idea what the impact is on the ICBT effect on the patients itself? Is there also a change in quality that the therapy has, if you know what I mean?
Not sure. So the therapists, right, they're new to the ICBT, and then they deliver the ICBT, and you want to know if there is an impact on the patients.
Yes. Is it in the same way? Okay, when you have the let's say the practitioners who handle the ICBT with the patients according to a process, and before it was implemented as usual, do the patients get the same kind of therapy, or do they experience it as the same kind of therapy?
Compared to face-to-face treatment, you think?
Yeah, no. The way how it's implemented, the way how it's brought to the patients.
Yeah.
Is there a difference? You know, I think I don't express completely well, but if you have a implemental as usual of ICBT.
Yeah.
Okay, so this is maybe not really structurized, but now, as far as I understood, you try to do it more structurized on organizational level, on individual level. But do the patients themselves experience there, or do they feel a difference in it?
That's a good question. Although we haven't started, right? So I don't know, but you can think about how it is organized would have an impact on.
Yeah, that's what I mean. That's what I mean. Exactly. So the way how it's organized, because once again, I missed a huge part of your explanation. I don't know whether it was already handled or dealt with or not. But that's a question I just have also in the implemental, which was not the objective once again of the implemental project, but it's still a question that keeps on going in my mind as a patient myself.
Yeah. But I think also we have in our project we have lots of patient representatives as well, and the perspective of the patient is really central here. But we haven't started, right? So don't have any idea. But I would guess it maybe would have. If you organize it in a different way. We know that from self-referral, right? Then when patients can self-refer, that's quite new. That's only to that in the Bergen area, it's only these patients that can self-refer to the treatment. They are really motivated, right? Instead of maybe go to the therapist's office and then they say, okay, you have these kinds, you have group, you have individual treatment, you have this, maybe you should try internet-based treatment, and that it may be more pushed in a way on a patient.
That's it. What I mean, the way how you implement or the way how you approach it to the patient.
Yeah.
If you're not, or by matters of speaking, very simple, if you're a not organized psychiatrist and you bring it to your patient in a very struggled way, it's completely different when you have used the procedure and really bring it to him very smoothly.
Yeah, and it's interesting, and maybe it touches on that we know from the data from one outpatient clinic that already uses the e-coping. When COVID hit, because they had really good effects, right? They've been doing this for a year, they had good effects, patients were satisfied, therapists were satisfied, and then the pandemic hit. And they pushed more internet-based treatments on the patients and on the therapist. So there was more dropouts, therapists weren't satisfied, and patients neither. But that's the thing, right? It's difficult because our government says, okay, by 2030, 20% must be accessed digitally. And then you have some patients that are maybe open to the idea of digital treatment. And then you have some patients for whom it's just not an appropriate care. So we don't want to push it on the patient, but yeah, in our project we use person-based approach. We have patients with us in the development of these kind of treatment, but of course it's not for all. It is for the people who think it's a good treatment for them.
Just to add it very simple in one sentence, and it's really, really very simple. It's maybe there is something like a COVID-19 kit. I mean, the pandemic has happened, and then suddenly much more people have to go into e-health. And is this kit correct or not? Is it a good kit? If you know what I mean, what can we learn out of that? This was a very rapid implementation towards the patient. What can we learn out of that? That's my part. It's okay, that's closed for me.
Well, thank you for your comment.
Did you want to add something, Tracy? I think I saw your hand up before.
Yeah, I think it was just to say, undoubtedly, the way implementation is organized impacts on the patients. What's more difficult is having a sense of which parts of that process behind the scenes patients directly see. So yes, it does impact on them. They have experiences that are useful for us. What they don't get access to is the whole process. So then I think that makes it important, but still maybe challenging for us as implementers to put all those steps in place and connect them up. And just hearing this discussion now makes me even more convinced that having some patients in as stakeholders in that process would help sort of close that gap a bit. I'm certain of that. So, I'm sure Robin and her team will be thinking about that a bit as she goes, as they go along.
I see a comment in the chat, maybe an idea for next project.
I think we have a lot of ideas for the next project. Did we have a comment from you, Kari?
Just a question about self-referral, because I thought that was a very great democratic idea, a way to bypass the bottleneck of waiting lists and everything. Do you know how many, if any of them who are going to implement the new sites, are they going to implement self-referrals?
I don't know.
You don't know, no?
No, I really don't know. And what we try to do is to have like an overview of these determinants and also communicate it to all the partners that, okay, in Bergen, they've done this and this, and they had this and this effect, right? That they can learn from each other. I believe it was a difficult process, but I'm not sure because I wasn't involved in that. It was a difficult process to get this self-referral right. And in the beginning, the patient self-referred, and then they got a pre-screening phone call. And then they got filtered out if they had problems that didn't fit the ICBT. And if they did, then they could ask, they were sent out some questionnaires online, and then they get the ICBT, and that was quite good. And now they changed it to that patients can go directly to filling out some questionnaires about their health, which means that then the outpatient clinic has all these patients they're responsible for. So with doing this online and not with phone calls, the workload increased, and they have to say, okay, you can't do the ICBT, but now we have to find another treatment for you. So that kind of format wasn't having the right effect, but they're changing it now. And what I understood is they're really happy with the self-referral, and the patients were really happy that they could self-refer and just don't have to wait for the GP and go there. But I'm not sure if the other outpatient clinics will, because they're autonomous, right? They can do whatever they please.
I hope they do, as I'm also a former patient in mental, and I think it's kind of democratic, and if you could, kind of empowering if you could refer yourself. Also, in terms of stigma, if there are things to overcome and you don't want to. Yeah.
No, absolutely.
The anonymity, I would say.
Yeah.
It's appealing. Thank you.
Yeah, thank you. Okay, I see on my screen that we have 1 minute. Is there another question that we can answer in 1 minute? A comment?
Robin, I just wanted to briefly comment on the self-referral part.
Yeah.
And just let you know that in the region of southern Denmark, we actually used the toolkit to a project where we put in an automatic stop in the self-referral, because also for us the task was too big with all the people who self-referred.
Yeah.
So we used the toolkit to put in an automatic stop, and the therapists are really happy about the project that came out of it. So just a brief comment to tell you what we did.
Well, thank you. It's not easy to do it right, but then so you didn't get any self-referrals?
All of them are self-referrals.
All right. Yeah. Okay.
But the automatic stop was that the group was made more eligible.
Right.
So that all those who weren't eligible were sorted out.
Yeah.